All right. Well, hello, everyone. We really appreciate you taking the time to be here today. My name is Dr. Amy Bender, and I'm the Director of Clinical Sleep Science at Cerebra. Cerebra is a Canadian technology company transforming the future of sleep diagnosis and therapy. Cerebra unites innovators and researchers with the common goal and passion of putting the sleep back into sleep medicine. And this is why we put together the Catching Up on Sleep webinar series, where we bring you hot topics in sleep presented by researchers on the cutting edge of sleep science that refuse to hit the snooze button, with Dr. Alex Sweetman as an example of this. I have a couple of housekeeping items before we get going. I wanted to let you know that you can use the Q&A function to input any of your questions. We also have an evaluation at the end, so I'm going to put that evaluation link in the chat where you can provide your anonymous feedback on the session. And also wanted to mention that the talk is eligible for continuing education credits. So I'll put that link in the chat. You can fill out that survey. And then for those of you who are interested in continuing education credits, there will be another link where you can fill out your email that are not attached to the feedback from the survey, where we can email you the certificate of completion as well. I also wanted to mention our next upcoming Catching Up on Sleep webinars. So we do have one May 2nd from 1 p.m. to 2 p.m. Eastern Time. During that webinar, we'll have Dr. Ali Azarbarzan, who will be talking about the characterization of sleep apnea beyond the AHI. Following that, we have another one September 20th from noon to 1 p.m. Eastern Time, which is the power of sleep, with Dr. Els Vanderhelm. And then on November 16th, we have one from 1 to 2 p.m. Eastern Time with hybrid approaches for sleep and circadian rhythm modeling in the real world with Dr. Olivia Walsh. So make sure you check those out. And I'll also put in a link where you can register for all of those events. I'll put that in the chat coming up. So without further ado, I'd like to introduce our speaker for today, Dr. Alex Sweetman. He is the Program Manager and Psychologist Education Committee Chair at the Australasian Sleep Association. He also has academic status at Flinders University. And interestingly, during his PhD at Flinders University, within his first peer-reviewed publication, he actually coined the term COMISA in 2016. I just find that so cool. He continues to publish in this area, a key opinion leader in this area. In fact, earlier this month, he recently published a systematic review on the impact of CBTI on COMISA. And he's also working on a CBTI program specific for COMISA. So that's kind of in the works as well. Today, he's here to talk to us about COMISA, which is definitely a new emerging area of sleep medicine. And we're really grateful to have him here today. And I will pass it over to you, Dr. Sweetman, to start sharing your slides.
Alrighty, perfect. Thank you so much, Amy, for the introduction. And thank you, Amy, and also to your colleagues at Cerebra for inviting me to present on COMISA today. I'm really interested in this topic, and myself and several other brilliant researchers around the world have been doing some, I think other brilliant researchers around the world have been doing great work in this area. So it's wonderful that you've chosen to shine a spotlight on COMISA for this presentation today. So thank you. As Amy said, my name is Alex Sweetman. I'm Program Manager with the Australasian Sleep Association, leading a primary care education and implementation project. And I have academic status at the Adelaide Institute for Sleep Health at Flinders University, which is where a lot of the work that I've done in COMISA has been undertaken. So before I begin, I would like to acknowledge that I'm joining from Kaurna Country lands. I would like to acknowledge the Aboriginal and Torres Strait Islander people of Australia as the traditional owners of the land, and also that the Adelaide Institute for Sleep Health is located on Kaurna country, very near a site of cultural and historical significance, the Warraparinga wetlands. So for the next 45 minutes or so, I hope to take you through a little bit of a whirlwind tour of COMISA, talking about the history of COMISA, what the prevalence of COMISA is in sleep clinics and population-based samples, some research looking into consequences and associations of COMISA before finishing on treatment research and some future directions. So as I said, there's a wide range of brilliant researchers in this field. I've tried to highlight a lot of different citations and researchers working in the COMISA space. So if you're interested in any of the references throughout the presentation, feel free to get in contact with me after for a reference list or with any general questions about COMISA as well. So let's get started. So I won't talk very much at all about insomnia alone or obstructive sleep apnea alone during the presentation. We know that these are the two most prevalent sleep disorders, insomnia being characterized by frequent difficulties falling asleep or maintaining sleep, and clinically significant daytime impairment. And chronic insomnia occurs in about 6 to 10% of adults. Obstructive sleep apnea, on the other hand, obviously characterized by frequent closure or narrowing of the upper airway during sleep, also associated with daytime impairments, and about 10% or up to 20% of adults experience moderate or severe sleep apnea. And for the last decade or so, I've been really interested in the comorbidity of insomnia and sleep apnea, or COMISA as we coined the phrase about 6 years ago. So it's simply the coexistence of insomnia and obstructive sleep apnea in the same person, which was first recognized in this publication in Science in 1973. And Christian Guilleminot and colleagues wrote, one obvious and important conclusion can be drawn from our data. An unknown percentage of the larger number of patients complaining of chronic insomnia have profound disorders of respiratory control mechanisms. So a prevalent yet then unknown percentage of those with insomnia who had sleep apnea. So how did the COMISA field emerge following this first publication? So as a bit of a thought exercise, Professor Leon Lack, one of my PhD supervisors, and myself thought it would be interesting to plot the cumulative number of publications looking at the comorbidity of insomnia and sleep apnea over time. So this is what this graph shows since 1973, this first publication. So there was quite a long period of dormancy in the field, a couple of other case studies, but it wasn't until the publication in 1999 by Kenneth Lickstein and 2001 by Barry Krakow and colleagues, which reported on the high prevalence of sleep apnea among a sample of patients with insomnia, and conversely the high prevalence of insomnia among a sample of patients with sleep apnea, that recognition and research attention was really started to increase in this field. So in the next few years, we saw more small pilot treatment studies, single-arm case studies of different treatment approaches, increasing awareness and more review articles. And then since 2018, some of the larger randomized control trials focusing on COMISA. So we produced this graph in 2018, and I think it's time for a little bit for an update. And I would expect the curve to keep exponentially increasing over the last 5 years as well. So before we go too much further into COMISA research, I think it's really important to acknowledge that these are two sleep disorders that we're talking about. And although insomnia and sleep apnea have unique symptoms, so some of the nocturnal symptoms unique to insomnia and daytime symptoms that are unique to insomnia, and also some of the unique symptoms or mechanisms of sleep apnea, including the AHI, other nocturnal and daytime symptoms of sleep apnea. It's also really important to acknowledge that they share several symptoms. So frequent awakenings from sleep, could be attributed to potentially insomnia, sleep apnea, or both conditions, same as non-restorative sleep or poor quality sleep. And a lot of the daytime impairments that we study and measure when we talk about insomnia, sleep apnea, and COMISA could be shared or attributed to each. So this is really important when we're talking about the prevalence of COMISA, so trying to assess the existence of each disorder in the known presence of the other, and also trying to assess treatment response to treatments for insomnia alone or sleep apnea alone. So we don't have a way of attributing these shared symptoms to one condition or the other with great certainty just yet, but at the moment it's just really important to be mindful that these exist. So this was adapted from an earlier review by Faith Leicester and colleagues. So what do we know about the prevalence of COMISA at this stage? So here's a couple of different review articles documenting the prevalence of insomnia among those with sleep apnea and the prevalence of sleep apnea among those with insomnia. So the same review by Faith Leicester and colleagues. In 2017, the review paper that Amy mentioned, we reviewed an additional 21 studies that had been published since that earlier 2010 review. More recently, a systematic review and meta-analysis of the prevalence of COMISA. However, some studies in specific samples were excluded from that one. And on balance, these are the prevalence statistics that I've been using. So about 30 to 40% of people with insomnia also have comorbid sleep apnea, despite the prevalence of sleep apnea in the general population being around 10 to 20%. On the other hand, about 30 to 50% of people with sleep apnea report clinically significant symptoms of insomnia or symptoms indicative of chronic insomnia, despite 6 to 10% of the general population fulfilling diagnostic criteria for chronic insomnia. So we think that insomnia and sleep apnea really frequently co-occur, and their comorbidity is higher than would be expected based on the general population prevalence estimates of either disorder alone, which is quite interesting. So quite a highly prevalent condition. Most of this research is from sleep clinic populations, so people with known sleep apnea or known insomnia. So what happens when we look at the prevalence of COMISA in the general population? So this is something that we wanted to do fairly recently with some Australian population-based data. We were really interested to look at the prevalence of insomnia, sleep apnea, and COMISA according to different threshold and different criteria as well within the same sample of participants. So we used two sets of threshold, a more liberal symptom level threshold in which we diagnosed or classified acute insomnia symptoms, so nocturnal insomnia symptoms, and sleep apnea symptoms were defined as a doctored diagnosis of sleep apnea or frequent self-reported choking arousals or snoring, so a high risk of symptoms as well as a doctor diagnosis. At the disorder level, we use much more conservative criteria, so insomnia was classified according to chronic insomnia disorder criteria, and sleep apnea was classified as a confirmed doctor diagnosis of sleep apnea on a home sleep study. So we can see that the prevalence of COMISA, unsurprisingly, was higher using the more liberal definition, so about 11% of the general population, and smaller using the more conservative criteria, down to 1.5% of the general population. But what was interesting, and this was the case across both sets of criteria, was that insomnia was more prevalent among those with sleep apnea compared to those without sleep apnea. And on the other hand, sleep apnea was more prevalent among those with insomnia compared to those without insomnia. So a frequent comorbidity of insomnia and sleep apnea still higher than would be expected based on the general population prevalence of each condition. So there's several studies now that have also looked at the prevalence of COMISA in the general population. Please reach out if you wanted more information on any of these. Prevalence estimates range from about 1 to 11%, and which is quite a large degree of variability here. But it's important to recognise that we're using different assessment tools and diagnostic threshold, not just for one disorder now, but for two disorders, which I think introduces more variability around this estimate from study to study. So that gives you an idea of the prevalence of COMISA in sleep clinic populations and the general population, but does it matter? So what are some of the consequences of this condition? Before we go into the consequences, I think it's important to recognise that people with COMISA not only experience frequent and prolonged difficulties falling asleep at the start of the night or maintaining sleep throughout the night, as seen on the sleep diary on the left here, but then when sleep is obtained, it's marked by more frequent respiratory events, cortical arousals, and awakenings, as seen on the PSG traces on the right. So unsurprisingly, it seems like the combined effect of insomnia and obstructive sleep apnea can have a really profound effect on daytime function, mental health, physical health, and quality of life. What about sleep? So do people with COMISA have worse sleep compared to those with either disorder alone? I think here it really depends on which sleep metric we're talking about and which groups and subgroups we're actually comparing. So we know that by definition, those with insomnia and COMISA experience worse nocturnal insomnia symptoms compared to those with sleep apnea alone or people with neither condition. And conversely, those with sleep apnea and those with COMISA experience a higher AHI or greater severity of sleep apnea compared to those with insomnia alone and those with neither condition. So this is by definition how we've defined the groups. But what about the associations of COMISA with daytime function, quality of life, and other health outcomes? So there's a fairly consistent message in the literature finding that COMISA is associated with worse daytime function compared to people with neither condition and often compared to people with either insomnia alone or sleep apnea alone. So this can manifest in worse daytime fatigue, lethargy, concentration difficulties. Some studies that have found worse neurocognitive performance in those with COMISA, and some studies that have reported higher levels of daytime sleepiness in those with COMISA compared to either condition alone. Stay tuned for a systematic review and meta-analysis of neurocognitive functioning performance in people with COMISA coming very soon, we hope, from the brilliant Dr. Megan Crawford as well in this space. So what about mental health? We know that both insomnia and sleep apnea are associated with higher rates of depression, and also that sleep disorders are a risk factor for incident depression symptoms and depression onset. So what about COMISA? Fairly consistent message in the literature that COMISA is also associated with higher symptoms of depression, anxiety, and stress compared to either disorder alone. So the graph at the bottom here is reporting on some Australian data from 700 males. Participants were characterised as those with insomnia alone, sleep apnea alone, and COMISA. And we can see that the prevalence of depression was much higher in the group with COMISA compared to those with either disorder alone. I'll also say I had some fun colour coding. So for the remainder of the presentation, insomnia alone gets this turquoise blue colour, sleep apnea alone is in orange, and COMISA is in purple, just to keep everything consistent and easy to follow here. So what about associations with physical health? There have been several studies looking at cross-sectional associations with cardiovascular disease. The literature isn't totally consistent on this association, but we also looked at this last year. So Bastian at the Adelaide Institute for Sleep Health has led some brilliant epi work in the COMISA space. We used the Sleep Heart Health study to look at the prevalence of cardiovascular disease at baseline, and then the longitudinal associations with incident cardiovascular events and associations with COMISA over time. So at baseline, COMISA was associated with a 70% increased likelihood of having a cardiovascular disease compared to people with neither insomnia nor sleep apnea in the fully adjusted models. But we also wanted to look at risk of incident cardiovascular events. So to do this, we excluded everyone with pre-existing cardiovascular disease. And as you can see on the graph on the right here, we tracked risk of cardiovascular events over time. Sorry, the color system, after immediately promising that I was going to use purple for COMISA, I've reverted to not doing that. We can see that in the unadjusted model, the COMISA line in the bottom here experienced an increased risk of incident cardiovascular events compared to those with neither condition. However, in the fully controlled model, this association was no longer significant, probably because we were working with a reduced number of participants here after excluding all of the participants with prevalent cardiovascular disease at baseline. So what about associations between COMISA and all-cause mortality? So in the literature, it looked like COMISA was a really prevalent condition that was associated generally with worse sleep, daytime function, quality of life, mental and physical health, compared to people with neither disorder, and often compared to people with insomnia alone and sleep apnea alone, depending on which exact metrics we're talking about. Despite the prevalence and morbidity of the condition, no study at that time had investigated potential associations with all-cause mortality. So we did this in a few different data sets, and I'll just present one in detail here. So we used the National Health and Nutrition Examination Survey, or NHANES data, and used the 2005 to 2008 baseline waves in which insomnia and sleep apnea were assessed in more detail, which gave us a sample of almost 7,000 US adults. And then at baseline, we characterized participants into those with neither disorder, which was our reference group, insomnia alone, a high risk of sleep apnea alone, or COMISA, which is those with both insomnia and a high risk of sleep apnea. And then we linked death registry data and followed participants up over a median of 9 years. So it's not always using retrospective cohort data. Sometimes we have to cherry pick which variables we use to construct different definitions, and the exact variables and measures that we want aren't always available. Having said that, the NHANES has brilliant variables about self-reported sleep symptoms and impairments. The only downside was that we didn't have overnight polysomnography in these data. So for insomnia, I think our definition was reasonably good. We defined insomnia as at least one frequent nocturnal symptom, so one of these 3 symptoms, and at least one frequent daytime impairment, so getting toward insomnia disorder there. For sleep apnea, in the absence of polysomnography, we recreated the stop bang, which is an 8-item self-report measure of a high risk of sleep apnea, to define high risk sleep apnea in this group, and also used a couple of different sensitivity and stop bang sub-scores as sensitivity definitions. And then again, COMISA was defined in anyone with both insomnia and a high risk of sleep apnea. So I can't take any credit at all for the statistics here. Dr. Johannes Melick led the statistics. He's a brilliant biostatistician and has done a lot of work with the NHANES data. Cox regression models were used to compare mortality risk between the 4 sleep disorder groups, and hazard ratios and 95% confidence intervals were used. And we developed these models and lists of covariates based on previous investigations of sleep disorder and mortality. So first we looked at an unadjusted model. Model 1 adjusted for socio-demographic variables. Model 2 additionally adjusted for behavioural factors. Model 3 additionally for chronic conditions. And finally, Model 4 additionally adjusted for potential mediators and moderators, including sleep duration, sleep medicine use, and depression symptoms. So what did we find? These are some of the baseline data. So I'll draw your attention to a couple of parts. So COMISA was prevalent in 3.3% of the sample, similar to that 1 to 11% range. The COMISA group had slightly shorter self-reported sleep duration at baseline compared to those with sleep apnea alone or a high risk sleep apnea alone or insomnia alone, and slightly higher prevalence of cardiovascular disease and depression. Interestingly, cardiovascular disease seemed to co-occur more with the presence of sleep apnea than insomnia, and conversely, depression seemed to co-occur more with the presence of insomnia than sleep apnea here. So what did we find? I'll orient you to the figure first. So compared to the reference group indicated by the dotted line, we have hazard ratios and 95% confidence intervals for those with insomnia alone, high-risk sleep apnea alone, and COMISA in the unadjusted model, and then incrementally adjusting for models 1, 2, 3, and the fully adjusted model here. Across each of the models, there was a significant association indicating that people with COMISA had an increased risk of all-cause mortality compared to those with neither condition. A hazard ratio of 1.56 in the fully adjusted model, whereas insomnia alone and sleep apnea alone were not associated with increased mortality risk in this fully adjusted model. Obviously, some limitations with this report. So defining OSA according to self-report symptoms is not ideal. However, I'll show you another couple of studies that we reported on which did use polysomnography to define sleep apnea. And also we weren't able to control for access to any treatments or potential mediators or moderators of the association between COMISA and mortality over time, which I think will be a really important area for future research. So what are some of the mediators between COMISA and this increased mortality risk? And then can we apply any treatments to moderate that risk? So Bastian has led, as I said, another couple of studies in the sleep heart health study cohort and Wisconsin sleep cohort, looking at the same question consistently, and these two, sleep apnea was defined according to polysomnography, and consistently across these different cohorts, COMISA is associated with about a 50 to 70% increased risk of all-cause mortality compared to people with neither disorder in fully controlled models, whereas insomnia alone and sleep apnea alone were not associated with mortality risk. A concerning finding and points to the great need to develop better ways to identify and especially better ways to treat patients with COMISA. So what do we know about the treatment of COMISA? So we know that CPAP therapy is still the recommended first-line treatment for moderate and severe sleep apnea, alongside lifestyle advice and weight management advice where relevant. However, CPAP is limited by poor initial acceptance of a trial of CPAP and suboptimal long-term use throughout the night in many patients. So it seems that an important question here is, what's the impact of insomnia symptoms on the acceptance and use of CPAP therapy? And I realize that I haven't included several other emerging and existing therapies for sleep apnea and insomnia other than CBTI because I'm limited on time, but happy to continue the conversation afterwards or via email with anyone that's interested in non-PAP therapies here. So what's the association between COMISA and CPAP use? Last year, we reviewed about 25 studies looking at the effect of comorbid insomnia symptoms on the acceptance and use of CPAP for sleep apnea. And these are two graphs that I've cherry-picked. This first one is from a medical science student last year who used data from a little over 400 people in the community with sleep apnea, and we asked them a lot of questions about insomnia symptoms and also access and use of different treatments. So compared to those with sleep apnea alone, those with COMISA were much less likely to have ever been recommended CPAP by a sleep physician. So it's possible that some sleep physicians are identifying the comorbid insomnia symptoms and that patients might be less likely to accept and use CPAP before even recommending CPAP therapy. Among those that were recommended CPAP, those with sleep apnea alone were more likely to accept a trial of CPAP and actually start CPAP compared to those with COMISA. And these are data from Simon Smith in Queensland and Simon's group. Among those that did accept CPAP, we also find an association between insomnia symptoms and average use of CPAP therapy over time. So people with no difficulties falling asleep at the start of the night had much greater average CPAP use of about 6 hours compared to patients reporting severe difficulties falling asleep at the start of the night, about 2.5 hours average CPAP use. So it looks like insomnia symptoms might be associated with reduced recommendations for CPAP, reduced acceptance, and reduced long-term use of CPAP throughout the night. So what about treating insomnia? So we know that cognitive behavior therapy for insomnia is the recommended first-line treatment for insomnia. Hundreds of clinical trials demonstrating the effectiveness of CBTI in the presence of lots of different comorbid conditions and also lots of different CBTI modalities. Probably 30 to 40 meta-analyses published at this point, documenting the robust effects of CBTI in treating insomnia. So an important question here is whether CBTI is effective in the presence of comorbid sleep apnea, and also whether CBTI improves any symptoms or the subsequent management of the sleep apnea by treating the insomnia. So I'll present a couple of different studies that that myself and some other colleagues have coordinated looking at the effects of CBTI in people with COMISA. So the first one here is comparing CBTI effectiveness in people with insomnia alone and people with COMISA. So this was one of the studies from my PhD. I conducted a chart review of participants or patients treated in an outpatient insomnia clinic. So over the course of about 20 years, Professor Leon Lack was establishing a really rich database of patients with insomnia treated in this outpatient clinic. We wanted to look at the effectiveness of personalized CBTI between participants with COMISA and insomnia alone. And we also wanted to look at CBTI as an isolated treatment. So we excluded anyone that was prescribed or not prescribed using CPAP therapy at any point during this treatment or follow-up phase. So we looked at data from 455 patients who completed questionnaires and a sleep diary at pre-treatment. All participants completed a diagnostic sleep study, which enabled us to define them as having either COMISA or insomnia alone. Participants were treated with 5 to 6 individualized treatment sessions from a psychologist and completed questionnaires and sleep diaries at post-treatment and 3-month follow-up. And we do have quite a bit of attrition from this study because this is a real-world sample, so we didn't have research associates or research coordinators following these patients up and reminding them to complete questionnaires or sleep diaries. So in these real-world samples, sometimes we do see much higher rates of missing data. So what did we find? Again, insomnia alone in blue and COMISA in purple. I've actually used my color coding this time. So in the top left, we can see that both groups experienced a large and clinically significant improvement in insomnia symptoms by post-treatment and 3-month follow-up. There was a significant between-group difference here. However, this was likely due to those with insomnia alone commencing treatment with slightly higher ISI scores, where there was very little difference between groups at post-treatment or 3 months. Looking at diary measured total sleep time, again, both groups experienced improvement in sleep time. Actually, there was an interaction effect favouring the COMISA group this time, who experienced greater improvement in diary measured sleep time, but again, probably due to a pre-existing difference rather than differences by 3-month follow-up here. Both groups experienced improvement in fatigue with CBTI that was sustained over time. The sleepiness scores are quite interesting. So the COMISA group commenced treatment with slightly higher Epworth sleepiness scores compared to the insomnia alone group. However, there were no differences between groups at post-treatment or 3-month follow-up. So the take-homes here were that 31% of patients in an outpatient insomnia clinic had comorbid sleep apnea. These were not patients presenting with an overt complaint or symptoms of sleep apnea. Their presenting complaint was insomnia. But despite this, about 1/3 of these patients had comorbid sleep apnea when tested on overnight polysomnography. Although there were some significant between-group interactions, our overall take-home was that changes in insomnia symptoms were not meaningfully different between the two groups, and both groups experienced moderate to large improvement in their insomnia symptoms by post-treatment and 3-month follow-up. So a couple of years ago, Peter Catcheside and I were really interested in the broader impacts of CBTI in this COMISA population, and specifically whether CBTI had any impact on the severity of sleep apnea in these patients. So it could be the case that bedtime restriction therapy might result in a small degree of sleep deprivation in patients with COMISA that could increase the AHI and sleep apnea severity. And similarly, the opposite could be true. CBTI may result in a reduction of sleep apnea severity through consolidating sleep periods. So this was quite an exploratory analysis. Some of the rationale was that it looks like CBTI is an effective treatment for insomnia in patients with COMISA. Quite a few previous studies had investigated the effect of CPAP therapy on improving insomnia, and this is a fairly well-accepted view in the sleep medicine community that insomnia symptoms might be a secondary symptom to untreated sleep apnea in a lot of patients with COMISA. So why don't we just treat them with CPAP therapy? Indeed, several studies have looked at this, and it looks like CPAP therapy is associated with about a 20 to 40% improvement in insomnia among those with sleep apnea. So sometimes that's true, but we don't have ways of prospectively identifying who's going to respond to CPAP and who's not just yet. So although there were some studies looking at the effect of CPAP on insomnia, there were no studies looking at the reverse of this. So what's the effect of insomnia treatment on improving sleep apnea? So we aimed to investigate the effect of CBTI versus no treatment control on changes in sleep apnea severity, the AHI here, from pre-treatment to post-treatment. So we used data from 145 patients with COMISA who had a psychologist diagnosis of insomnia and sleep physician diagnosis of moderate or severe sleep apnea, according to Home PSG. None of the participants were using any treatment for sleep apnea during this phase of the study. So this is part of a larger study in which all patients went on to commence CPAP therapy later on. So it would be down here if we included the full flow diagram. These participants were randomized to CBTI or no treatment control. Smaller rates of attrition, because this was a well-controlled prospective research study, and then were followed up again at 6-week follow-up, questionnaires, sleep diary, and another home-based polysomnography study. So we wanted to look at the between-group changes in sleep apnea severity from pre-treatment to 6-week follow-up. We also know that the AHI is strongly impacted by sleep stage, so stage 1, 2, 3, REM, and also sleep posture, so supine versus non-supine sleep. So we also wanted to look at the impacts of sleep stage and posture, and also control for these effects when exploring the impact of CBTI on AHI. And as I said, these were patients that were not using any treatment for sleep apnea at this phase of the trial. So what did we find? I'll take a little bit of time to orient everyone to this graph because there's a little bit going on here. Any data above this 0 mark indicates an increase in AHI by post-treatment, and any data below this 0 mark indicates a reduction in AHI by post-treatment. We then have the control group in grey and the CBTI group in blue, and we've split by sleep posture, so supine and non-supine in dark and lighter shades, and also by sleep stage 1, 2, 3 REM and collapsed across all stages. And then finally, these two orange and green bars are collapsing AHI across posture and stage in each condition. So you can already see the general trend of the data here. In the CBTI group, there was a reduction in AHI pretty much across all sleep stages and postures, but much less consistent effects, and in fact, the opposite effect in the control group. So there was a significant group by time interaction effect here, in which CBTI was associated with a 5.5 point reduction in AHI, whereas control was associated with a small increase in AHI by post-treatment, so a 7.5 point difference. CBTI was also associated with a reduction in objective minutes spent awake throughout after first falling asleep, and also a reduction in the number of awakenings throughout the night. So it's possible that CBTI consolidates sleep periods, reduces time spent in transitional sleep-wake phases, and therefore reduces the AHI in participants with comorbid insomnia and untreated sleep apnea. So we think, although this might not be a clinically meaningful effect, we think it's a very interesting effect to look further into. And I would love for someone out there to replicate this study and also to look at more mechanisms and mediators that might be underpinning this relationship. So Amy also mentioned a fairly recent systematic review and meta-analysis published a month ago or so. So this was a truly international collaboration between Australia, Scotland, and the US. We were aware of several studies that had looked at the effect of CBTI in patients with COMISA, but to date, no other study had systematically reviewed or synthesized these literature. Although there's a few randomized control trials, we were interested in casting the net quite wide and capturing all sorts of different research designs, so including case studies, single-arm trials, randomized control trials, cohort and quasi-experimental studies, and so on. So we didn't focus just on randomized control trials here. And also there aren't that many RCTs in the COMISA field just yet. So we wanted to be more liberal in our systematic search criteria. So the overall question was, what is the effect of CBTI on insomnia symptoms in people with COMISA? Some of the methods, a little bit dry, prospectively registered. These are the two databases that we searched. We drafted and refined search terms related to insomnia, sleep apnea, and CBTI. Also used hand searching and forward and backward chain referencing, and at least 2 authors reviewed all abstracts and titles, extracted data, and 2 authors performed quality assessments of each study. So what did we find? It's the flow diagram. 295 studies were screened, of which most were excluded, largely because they were review papers. 27 full texts were reviewed. Several were added after hand searching and forward backward chain referencing, and some were excluded because although the sample included participants with COMISA, subgroup data for the COMISA group were not reported, were not available, or the authors didn't get back to us or weren't able to extract those COMISA subgroup data. So this left us with 14 independent samples and 7 secondary analyses of those 14, 9 independent studies of which were suitable for meta-analysis, including the Insomnia Severity Index as an outcome measure. So these are the 9 studies that we looked at. Insomnia Severity Index as the outcome measure. Overall, a Hedges G of -0.89, which is a large effect size overall of CBTI on insomnia symptoms. A couple of things to draw your attention to, a fair bit of variability from study to study here. The 2 studies crossing the 0 threshold had the smallest sample size, I think 5 participants in each of these, and therefore larger confidence intervals, which is what we would expect. And some studies, the ones in the yellow or orange box here, administered CBTI concurrently with treatment of the sleep apnea. So we also looked at subgroup analyses of the effect of CBTI in people with treated and people with untreated sleep apnea. And in both cases, CBTI is associated with improvement in insomnia symptoms in these groups. So finally, what's the effect of CBTI on the CPAP use? It looks like CBTI is a really effective treatment in the presence of treated and untreated sleep apnea. A lot of authors recognised that insomnia was an obvious barrier to the acceptance and use of CPAP therapy, and intuitively this makes sense as well. So if someone's already having difficulties falling asleep at the start of the night or long awakenings throughout the night, they're more protective of their sleep and concerned about potential threats to their sleep. It can be really hard to introduce CPAP therapy into that situation, to ask someone to strap on a pressurized mask and wear it for the duration of their sleep period, or time in bed period, in fact, including when they're awake during the night. So intuitively, it makes sense that insomnia symptoms might reduce acceptance and use of CPAP therapy. However, we know that we can treat these insomnia symptoms. Does treating insomnia have any impact on improving acceptance and use of PAP therapy in this group? So several research groups around the world have looked to find an answer to this question. We have 4 published RCTs and one from Rachel Mamber and Jack Ettinger's group, which is still emerging. So Bjorn Bjorvatn and colleagues in Norway used a self-guided CBTI booklet versus self-guided education control. There was no between-group difference in insomnia symptoms in this study, and therefore no carryover effect on improving adherence to CPAP use. The other 3 published RCTs used therapist-delivered CBTI programs, all of which had a significant and clinically meaningful impact on improving insomnia severity compared to control, and 2 of which led to increased adherence to CPAP of about 60 minutes per night over time. So there were some methodological differences from study to study, and I promise you the author groups here plan to work together to integrate these data and understand what's going on, but clearly more research is needed in this area with the conflicting results. And finally, a really interesting stepped care model of CBTI, including online CBTI. So we've seen abstracts, some conference abstracts already, and it looks like online CBTI is effective in participants with COMISA. But we don't know the impact on CPAP use just yet, so pending results here. So finally, what are some of the potential future directions in the COMISA field? So first, what's established? I think it's quite well established that COMISA is a prevalent condition, especially in sleep clinic samples, that's associated with significant mental and physical health morbidity. I think there's also quite a bit of research showing that therapist-delivered CBTI programs are effective in patients with COMISA. So what are some of the potential next unanswered questions? I think it's really important to develop an idea of the prevalence of COMISA in general population cohorts, and also try and understand how COMISA develops. So longitudinal studies with more frequent assessment time points, to understand whether COMISA develops from insomnia coming first, sleep apnea coming first, or both conditions developing at the same time. I don't know yet. We could make some theories, but I think it would be really interesting to look at the development and onset trajectories. Obviously, a lot more work to be done in developing and refining tailored treatment approaches for COMISA. We've barely scratched the surface here. And once we start to develop these different treatment approaches, to then try and hunt for baseline predictors of which treatment approaches are most appropriate for which COMISA subgroups. Similarly, although therapist CBTI has been tested in a few different studies in people with COMISA, I think it's really important to develop and test other CBTI modalities as well in the COMISA group, including self-guided digital programs, brief behavioural programs, one-shot CBTI. So a lot of the different CBTI modalities that have been developed over the last few years. Finally, I think it's really important to implement COMISA management approaches throughout the health system. So especially in sleep clinics worldwide that still mainly focus on the diagnosis and management of sleep apnea alone, despite the 30 to 50% of these patients reporting clinically significant insomnia symptoms where we think they require tailored treatment approaches. So it would be quite simple to administer standardized insomnia questionnaires And access to CBTI might be improved through several different modalities in sleep clinic settings. Finally, I'm really interested in bidirectional relationships between the mechanisms and manifestations of the two disorders. For example, what's the relationship between insomnia and the respiratory arousal threshold? Some great work going on in Australia by Dr. Amal Osman and Elliot Brooker here. And some other potential, currently theoretical, I think, associations between bidirectional relationships of the two conditions. Thank you so much for listening. Thank you again, Amy and team, for inviting me to speak today. Wonderful that you've turned a spotlight on COMISA, and it's been great generally to see the increased recognition of COMISA throughout the sleep medicine community, so thank you. I would also like to thank all of my colleagues and collaborators at the Adelaide Institute for Sleep Health, shown on the left here, where a lot of my own COMISA work has been undertaken. I had some brilliant supervisors throughout my PhD that fostered my passion in this area, especially Professors Leon Lack and Doug McAvoy. And if there's any early career researchers or clinicians listening with an interest in COMISA, I'd like to pass on that support if I can. So please feel free to reach out to me and I'll help answer any questions or guide you or point you to references if I can. I'd also like to thank my colleagues at the Australasian Sleep Association, brilliant colleagues who have been instrumental in the primary care education and implementation work that we've been doing, and generally a lot of other Australian and international research and clinical collaborators in the COMISA space. So it's been brilliant to work with a lot of people around the world in this space. Alrighty, I might hand back to Amy, and happy to answer any questions or discuss any of the research further. Thank you.
Thank you so much, Alex. This has been amazing. We do have a lot of questions in the Q&A here, so I'd like to get to those. It looks like the first one coming in is, did you look at any of your results by sex differences, is one of the questions.
I haven't yet, but I intend to. So that's a great question. I had a really early preliminary look, but I don't believe there were any meaningful differences between the two groups. So I would have looked at that in my PhD data, which was comparing CBTI versus no treatment control on insomnia symptoms and subsequent CPAP use. Watch this space is my answer to that one.
Very nice. We also have another question on, can you share a little bit more about the reasons for the AHI reduction with CBTI, which is something that's so fascinating. I'm wondering if you can maybe comment on kind of a potential mechanism for that.
Yeah, it's a great question. So that was quite surprising to us when we found it. In my mind, it could have gone either way. So equally so, bedtime restriction therapy, in my mind, might have resulted in a small degree of sleep deprivation, which in previous experimental studies has been shown to increase the AHI. So it was quite surprising to me that there was a consistent improvement in AHI with CBTI. What are some of the potential mechanisms? I think reducing the periods spent in transitional sleep, where the airway might be more vulnerable to collapse, might be part of the key, and potentially modifying the respiratory arousal threshold. So unfortunately, we didn't have interim data from week to week of CBTI to track what was happening or when those changes in AHI were occurring. We only had pre-treatment and post-treatment data. So I would love to do a future experiment with better measures, pre-treatment, post-treatment, but also nightly measures of sleep apnea severity with some of the wearable or under the mattress devices to work out at what point during CBTI the AHI is actually reducing, and also better measures of some of the endotypes of sleep apnea to work out if there's any association with the respiratory arousal threshold or potentially other non-anatomical traits.
That's very interesting. We have a question from David Russell who is asking, has anyone been looking into using adaptive servo ventilation in the treatment of COMISA? So I think trying to get at maybe a less subtle version of CPAP potentially.
Yeah, I think Barry Krakow in the US has done a couple of different trials. Reach out to me via email and I'll share some of those publications afterwards.
Sounds good. And then we have a question, is there a difference between insomnia with short sleep duration and insomnia with normal sleep duration in the contribution to COMISA?
I think not in my own research, we haven't found the signal. And with the mortality associations, the association between COMISA and mortality persisted both before and after controlling for sleep duration, whether that was subjectively measured sleep duration or objectively measured sleep duration. So in that sense, no, it didn't seem to have an impact. Again, reach out to me via email. I think there was one article very recently published looking at the combination of COMISA and short sleep duration in people with diabetes. I'm trying to recall that. Reach out to me by email again and I'll dig up the reference for you. I think that's the only one so far that's specifically targeted short sleep duration in COMISA though.
Okay. So Kevin Adley is asking, is CBTI effective at increasing CPAP adherence in COMISA patients?
Yeah, so I guess that question preceded one of the final tables I had. Short answer is we don't know yet. So some trials suggest that CBTI does improve CPAP acceptance and use by about 60 minutes per night. And other trials have reported that CBTI has no effect on CPAP adherence. I think there's some important methodological differences between the studies that we need to dig into. And I think the next important question is whether we can identify in which patients CBTI has the largest effect on CPAP acceptance and use compared to the patients where CBTI doesn't seem to have much effect at all on CPAP acceptance and use, which would allow us to start developing more personalised treatment approaches or pathways for people with COMISA.
Very nice. And then let's see here. We have a question about since CBTI might improve OSA symptoms, is there any improvement in insomnia symptoms with CPAP? So maybe the reverse there, or does this result suggest that we theoretically should treat the insomnia first for best outcomes?
Yeah, it's a great question. I would love to be able to identify which patients are most appropriate for CBTI first versus CPAP first. But we haven't found any consistent predictors yet that we're confident enough in to share with the whole community, the whole sleep medicine community. So the start of the question, does CPAP therapy improve insomnia symptoms? Yes, in a subsample of people with COMISA, it does. Overall, I think we reviewed 9 to 10 studies looking at this a couple of years ago, and overall, CPAP therapy is associated with about a 20 to 40% improvement in the ISI. Some of that improvement might be driven by some of the shared symptoms, which was one of the earlier slides. So CPAP therapy might improve some of the daytime impairments that are shared with insomnia and also measured by the ISI, and that might be why it appears to reduce insomnia severity overall. Yeah, but I think more importantly, it's important that we work on identifying those patients, those 20 to 40% of patients prospectively. So there's some ongoing work in that area still.
Great. Well, I think we are all out of time. I just want to thank everyone for attending our first inaugural Catching Up on Sleep webinar. It was a fantastic one. Thank you so much, Dr. Alex Sweetman, for your time and enlightening us in this new emerging area of sleep science. And join us again for the next Catching Up on Sleep webinar. And definitely fill out those evaluations. And also I put the link to register as well for the next webinars. So thank you so much, Alex, for your time.
Thank you so much for inviting me, and thanks everyone for listening in and for the questions. Feel free to reach out afterwards if there's more questions coming.
Absolutely. All right, take care.